more than a lot of things that we come across, actually transfers require a really collaborative and interprofessional approach to patient care. And this relies on good communication between staff members and with respect for others' ability and experiences. So there might be different skill mix on each day. There might be someone on for the intensive care team or the anaesthetic team that hasn't had much recent exposure to paediatrics. It might be out of hours. So your paediatric anaesthetist, certainly in my trust in Newton, isn't necessarily available during those times. So therefore, working together, using the tools that you have available and having a systematic approach to that patient is really important. So first of all, you need your decision to transfer. And once you've made that decision, an early heads up to the transfer team or the intensive care team is important. Even if you work at a tertiary centre, there's still transfer risks within the hospital. Getting up and down to CT, getting over to the PICU. That team may be busy initially, so it's managing your resources at the time available, especially in this current environment. In my trust, probably we're averaging about one paediatric transfer out a day at the moment, because of the respiratory surge and because of general sick children that we haven't seen for a while. So it's a common occurrence at the moment. Pre-transfer stabilisation, as I've said, is really important. And then the management of the transfer itself, which may not be done by you, depending on the severity of the patient. It might be a nurse, it might be a doctor, it might be your ITU team, or it might be the transfer teams that's coming to collect the patient. I think the decision to transfer is often based on the level of care that the child needs. So we need to understand each hospital's capability to meet those needs. So there needs to be a bit of understanding of levels of paediatric care. So I'm going to run through that really quickly. Level 1 paediatric care is provided by all hospitals providing inpatient care to children, and that's things such as oxygen monitoring, Optiflow, arrhythmia management, DK, asthma, bronchodilator therapy, maybe nebulized adrenaline for upper airway obstruction and or apneas. And the management of these and the funding is a responsibility of the CCG. So that is most acute hospital trusts. Level 2 paediatric care may be specialist or non-specialist and are provided in tertiary hospitals and a limited number of DGHs. So that might be status epilepticus on continuous infusion, long-term ventilation needs, arterial or central venous monitoring, acute tracheostomy care, so in the first 7 days, NIV, a sick child that's required extensive fluid boluses over a period of 24 hours, and maybe inotropic treatment. So some places provide this level 2 care as well, and this is slightly differently commissioned by NHS England. Level 3 paediatric care is those that have your PICUs on site. So they're usually in tertiary centres or specialist hospitals and can provide all 3 levels of paediatric critical care. They provide care for children requiring intensive care and monitoring. So what we expect on a PICU is intubation, ventilation, organ support, and particularly intensive medical and nursing supervision. They also do a lot of post-op care for planned surgical procedures. And again, this is commissioned by NHS England. The case mix and level of intervention performed varies quite a lot between units, and the percentage which are planned and unplanned. But as a rule of thumb, about 60% of admissions to PICUs are unplanned, whereas 40% are your planned or post-op patients, etc. Top 3 indications for admission are cardiovascular, respiratory, and neurological. Certainly we're seeing that respiratory element more at the moment. What's important is that level 3 units need to cooperate as part of a national system with other units to deliver optimal flexibility during periods of peak demand. Certainly we saw during the initial pandemic with COVID that PICUs were offering support to adult units if there was an element of them being overwhelmed. Certainly it's not something that can be offered by them anymore, with needing to deal with their own surges of patients, and actually it's being looked at the other way of trying to, if any adult units can hold the older children if possible. But again, it's working together, having a national system and putting the patient in the best place possible at the time. People, who do we need for stabilising that patient? So who is involved in staffing your stabilising patient in the ED for that child? So with any sick child, the paediatric consultant and registrar are involved very early in their care. Most importantly, I think you have your paediatric nurse who needs to be HDU skilled, and especially on the initial presentation and stabilization, you would almost certainly need more than one of those skilled nurses. You'd have your anaesthetic team, registrar, plus or minus consultant, and obviously you have your EM registrar and consultant as well. I think, especially in things like cardiac arrests, this is the bread and butter of the EM physician. We do it day in, day out, and it's very much my opinion that we are some of the best people to provide that team leadership in these stressful situations. So I think it's really important that we all work together. And certainly I'm not a proponent of walking off and leaving the paediatrician or the intensivist on their own with these sick children. It really needs all hands on deck in a controlled manner. Then you're looking at your smaller children, so under 3.5 kilograms. You may be in a unit that has access to NICU or neonatal specialists, and workload permitting, they may be able to assist in stabilisation. So certainly in my department in Luton, we have NICU on site. They are always very helpful, especially in the initial intubation, and offering advice, but they cannot stay with that patient whilst waiting for a retrieval team. So it's skilling people up where necessary. I think for children under 3.5 kilograms, many staff are practicing outside of their normal scope of work. So you have to accept standards in accordance with that, but it makes teamwork, support and kindness, I think, even more important in these situations. And that might be where your paediatric registrar, who's just completed a NICU posting, becomes even more important in this situation with the young children, because understandably your anaesthetic or consultant intensivist on the adult side are always going to feel out of their depth in these situations, so it's providing the correct support. And finally, an ODP. I think we don't often think of using our ODPs enough. If you put out an arrest call, then automatically they will come. We only put out paediatric arrest calls in my department, not adult arrest calls. So if we're maybe doing a planned intubation or a planned response, often we would call down the intensivist or the anaesthetist and not think of the ODP. Sometimes they get them themselves, but I think they're a really useful pair of hands in helping assist with the airway of that child if that's what's required. So what else do we need to look at pre-transfer in terms of stabilising that child? I think we're all used to the CATS website, so cats.nhs.uk, and accessing it. Often when we've decided that they need a CATS or a PANDA transfer, and often when we're thinking of the intubation side of things. Actually, the drugs calculator, so you do the in a hurry and you drop down, the first one you reach is the electronic drug calculator. You put in your weight. It has many useful doses on it, so not just anaesthetic or sedation drugs. It has on it your cardiac doses, your bronchodilator infusions, as we've just had a discussion about that. It has on it many useful things, so not just your sedation doses and things like that. So I would really encourage you to print it out early in the management of your sick patient, and not just when you're thinking of the intubation part of it. And then below that, there's the emergency intubation checklist. We've had a talk about intubation earlier, but I just want to reinforce the importance of using it. So the use of a pre-intubation checklist, verbalization of an airway plan, adequate resuscitation prior to intubation, induction dose titration, and the use of apneic oxygenation with end-tidal CO2 to confirm your position are associated with reduction in adverse intubation related events in emergency airway management. So it may be that they aid first pass successful ETT rate without hypoxia or hypotension. So undoubtedly the checklist will ease some of the stress and help the team support the process and understand the current risks for the patient. And I think as these are generally very sick patients, the more we can tick box how we manage them and make sure all the team is aware of the mental model that we have going forward, the better care that patient is going to get. So looking at equipment, briefly we've looked at ventilators before, so I'd be interested to know what ventilators you have in your departments. This one is a Hamilton T1 transfer ventilator, and the benefit of this is that it can be used from neonates to adults. So this has only been in our department probably for about the last 6 months. What's really important is that you have familiarity with your equipment. What's useful with this is because it covers all ages, your anaesthetic team who may not be used to such a small baby will be happy with the ventilator. So it's part of helping reduce their anxiety managing this patient. So that can be used in all ages. We certainly still have an Oxylog 3000 ventilator, and it's suitable for children weighing over 15 kilograms and works very well as well. And then with smaller babies, so neonates up to 20 kilograms, you may well need your baby pack ventilator. In our hospital, neonates would not be our neonatal team are not happy with the Hamilton ventilator, but they're certainly happy with the baby pack ventilator. So again, it depends. If you're asking for their help, you need to know where their skills sit within the ventilators that are being used, although the trust is trying to go trust-wide with the Hamilton ventilator. So ensure you're happy with your equipment, make sure you're happy with one of them, and you can meet all weights of babies that might be coming to you. So equipment, looking at what other equipment you need, this certainly isn't exhaustive, but an A to E approach of it can help you visualize it in your mind. So your cuffed or uncuffed ETT, obviously we're using uncuffed much more these days, but it depends on the presentation. Pulse oximetry and tidal CO2, intubation equipment. In our department, we have an adult airway trolley with a kit dump picture on top, which is really useful. So I think it's a quick win quip for a trainee to introduce a pediatric one. We certainly have a pediatric airway trolley, but it doesn't have a kit dump on top of it in terms of the layout of what you need. So it's an aid memoir when you're getting your kit ready for the intubation to have it there ready. Your bag valve, mask, tube, tie, etc. Within B, you need your correct ventilator and the correct circuit attached to it. So obviously different weights of patient will get a different circuit, make sure they're available. You will need to auscultate. These children have a limited reserve, so can desaturate quickly. You want to be able to auscultate, make sure your tube position is into the correct length, or oxygen, etc. And an early NG tube is very important in any child that is being intubated to assist your ventilation. Within C, obviously monitoring and non-invasive plus or minus invasive blood pressure monitoring, IV lines, IV fluid, urinary catheter. I don't think we think about catheter early enough in children either, but whilst documentation is being completed, the transfer team is arriving, a urinary catheter is really useful. Drugs and infusion pumps, the correct sedation, monitoring the child in terms of are they effectively sedated. Don't forget the pupils, have a pen torch ready so that you can monitor pupils in these people. And obviously temperature control is really important. We rarely aim for hypothermia these days, so maintaining a temperature above 36.5 is really important because we're often exposing these babies for prolonged periods of time, and that will not help their recovery in the long term. So going on further, obviously you're going to have your transfer monitor. Make sure you have it handy, people know how to use it. The transfer trolley, it's amazing how much time it takes to get the patient onto the transfer trolley with the equipment correctly secured. So make sure you're aware of that time process and you work together to achieve that safely. What I will say, I've put exclamation marks next to make sure your equipment is secured, because in my department, a Hamilton ventilator has been dropped on transfer, as has a Oxylog ventilator, which both times has cost over £3,000 to fix that ventilator. So not only are we trying to make the patient safe, we're also trying to make our equipment safe and have respect for the processes that are involved. Oxygen, we need to make sure we have the correct amount. I'll talk about that briefly in a bit, and also the appropriate restraint device for the child. Now, obviously the ambulances usually carry this, but think about it. We don't want everyone to be rolling around in the back of the ambulance. The grab bag is really important. So be familiar with it and take it with you on any transfer, even if it's just within the hospital, if it's just a CT and back. There's lots of things within it that you can grab quickly: syringes, cannula, gloves, needles, extensions, your laryngoscope blades, suction fluids, MPA, OPAs, etc. Scissors. But if you don't know where stuff is within that bag, you're not going to be able to access it quickly. So don't forget your grab bag and be familiar with it. Battery packs are hugely important. Certainly I have been on transfers to CT and my ventilator has run out of battery, and I'm hugely thankful that I have remembered to take the battery pack with me. So we all know how busy the environment is at the moment, and you might be, often we don't have a huge amount of ventilators in our department, so one patient might be away on a transfer and you're using another ventilator which might not have been properly charged. So just never falsely reassure yourself that you've got enough charge. Please take the battery pack with you. Suction is hugely important, especially in the non-intubated patient, but always take it with you. You can put these things under the trolley. You're not going to be transferring them on your own without help. So to minimise the time the transfer team needs to prepare the patient for transfer, consider the following before the team arrives. And this is common sense, but I think we really fall down in a lot of these things with documentation. And whilst we might be delivering the best care to the patient, we're not always documenting it thoroughly and covering ourselves. And also we're not always communicating particularly well. So please make sure you update the family, let them know the plan, why there's a need for transfer, where that's likely to be. You can photocopy notes, make sure that investigation results are in the notes, so CT reports, blood reports, make sure the drug chart is up to date, has been signed for and is photocopied. Obviously make sure there's a transfer letter with relevant history, and it's important, especially with these children, to highlight any safeguarding concerns. Again, radiology, make sure it's been transferred to the relevant receiving hospital. I think we're used to that with trauma patients, but we often wouldn't necessarily think of it with our sick medical patient, but they will have had imaging, whether it be CT heads or chest x-rays, and it's important that gets transferred over on the electronic systems, and if that's not possible, make sure it's put on a CD to go with the patient. Patient preparation, again, is really important. Name bands, I don't think we think of it so much. The nurses are very good at doing it, but often in the busyness of getting everything prepared, you've forgotten simple things like name bands. So ensure they've got a name band. If they're intubated, make sure that it's secured using the correct strapping. You may have wanted to do a push test, but if your transfer team if someone is coming to do that, be it CATS or Panda or a transfer service, and they will have their own tick list to follow as well. But this is all useful to show that we've done it and thought of it. Confirm and document the ETT position on chest x-ray. Type T2 level is ideal for transfer. If you've done a chest x-ray and it's needed to be changed, document it and where it's been changed to. Ideally, they're stabilised on a suitable ventilation mode. They've had a recent blood gas and sugar. They've got the gastric tube and the minimum 2 points of IV access securely fastened. Don't be afraid that it's an IO. It's useful to give all the drugs as we've discussed earlier, especially if it's time critical and there's been difficult access. Don't waste time where it doesn't need to be wasted. Infusions need to be fully labelled and documented on a drug chart, and pupil responses monitored. It's important to consider the duration of transfer. So have you got sufficient fluid, sufficient drug infusions and enough oxygen demand with you? Oxygen demand, so it sounds obvious, but we need to think about it. Within the hospital, always take a spare cylinder with you. You never know, often they can imply that they're full and they're not at all. Even better, if you want, calculate it. This often comes up in exams. I can't say I've ever done it, but it is completing your task if you do this. So if you want to calculate it, it's your tank pressure minus your residual pressure multiplied by the cylinder constant divided by the flow rate. And this gives you the time in minutes that the cylinder will last. I'm not convinced if we did it, we'd necessarily do it accurately, but always carry extra with you and think about it. If you're going on the ambulance transfer, transfer to their supply as soon as possible. They carry 2 large F-type cylinders, which have over 1,300 litres of oxygen in them each. So if you do that early, you're not going to run out and then be stressing that your cylinder has run out. Another thing to think of is who is going with the patient. So what patient escort do they need to maintain safety? Now, it's obvious if the patient is intubated and they're a level 3 patient, they need ITU support. But it might be that they're a level 2 patient, so you need to consider the competency of staff going with them as to what the requirements of the patient are. So risk factors for the patient that might mean they need more than just a nurse going with them would be high frequency observations, so more than 1 hourly. The patient is requiring oxygen or ventilatory support. They've got infusions or blood transfusions running. Certainly if they're agitated, confused, or have significant behavioural concerns, is that patient safe to transfer as they are? Certainly not one person alone should be doing that. Obviously with trauma, if there's any suspicion of unstable injuries, and they're high risk, if there's a tracheostomy in situ or any other drains in situ like chest drains, if they've had a history of seizures within that presentation, any safeguarding concerns, and also if they're needing any sedation. Think of it and think who would help with it. So to help with that, this nicely in 4 sheets encompasses all that you need to think about with your safe pediatric transfer. It's your stop tool. So this is on the, again, on the CAT site there in the drop down menu. And we should be using it and we should be referring to it. It may be that your hospital has their own transfer documents, but this is being pushed more and more nationwide. And I think given the variety of trainees and how we move around the region, if we're all using the same one, again, it's consistency and it's likely to be safer. You don't need to put a huge amount of information into this form. It's often a tick box with a few details because there's going to be more details in the notes, but it's key points that need to be made and that need to have been ticked off that maybe we would forget about. So obviously there's the patient details, the date and time of referral, who made it, and to which hospital and which receiving team. It's amazing how easy it is not to have documented names and times when we're looking back and trying to timeline things retrospectively. Summary of what's happened and any discussion or advice that might have been received and exactly the reason for transfer. Then at the bottom, it's who might need to go on the transfer based on the risk assessment that's done on the second page. So we'll pop to that. And that is a basic thing that looks at the airway, the respiratory issues, and anything that might be outside of a normal range of observations, or if they're intubated and ventilated. C, is there anything worrying on the gases? What are their obs sitting at the moment? Have they had fluid boluses? And D, what's their GCS, etc. And then based on that, if you've triggered it with anything, as soon as you get one trigger, you're definitely going to need a nurse and a doctor. And then if it's a level 2 or 3 patient, you're likely to need both with the anaesthetic support as well. So once you've triggered it, you can go back and then click at the bottom, tick at the bottom who is needed to go. And then this whole page is a summary of what we've already discussed, basically. So, but with the names of the people going, again, that's really important. The fact that it's been communicated correctly, you thought about the equipment and what you need. And this 4th box here, transport, I think is really important as a timeline. So the time the ambulance service was called, the ambulance reference number, the arrival time at the referring hospital, and then it's reminding you people are going on transfer to think about phone, etc. Things that we need to monitor on the patient as we go, and then the documentation at the bottom. So your referral letter, the copy of your notes, etc., etc., and then your copy of your stop tool. The observation chart is there in it. You're not going to be going on a transfer and not documenting obs frequently. They should be being done at least every 15 minutes. And then you see at the bottom, it gives you a small space for any details of any instance that may have happened on transfer that would need to be reported back. But then time of arrival at the base and time of the patient being handed over. Okay, so a really nice, concise tool to use to assist with the safe transfer of these patients. And I think often as a doctor at the stabilising hospital, we package them and get them ready to go. And the transfer itself is stressful for the nurse involved. So if they've got, if they may be with their anaesthetic team, but they often don't know that anaesthetic team. And this documentary tool really helps them as they go along and ensures that we thought about things and it's going to be safe. So please use it. So I think it's important to mention time critical transfers. So certainly in my hospital, if it's a trauma transfer, a neurosurgical transfer, or an urgent neuro transfer, this may not be covered by your transfer service, be it CATS or PANDA in this region, as it may delay things. So therefore, it will fall within the remit of your hospital anaesthetic team to help deliver that transfer. And that needs to be in as timely a manner as possible. When the patient is ready to go, you may think, oh, it's easy to book a blue light ambulance. Actually, currently, it's all over the news, isn't it? The delays to get patients to hospital because of lack of availability of ambulances. And it's the same the other way around when we have urgent transfers out of the hospital. So there's a process that you can follow to help with this. What you may not realise is we pick up the phone and ask for a blue light ambulance, it's not going to arrive in 3 minutes. By the nature of the hospital environment, whenever we have a transfer, it will always be given a category 2 assignment. It won't be category 1 like it might be in the community. And they will then give you an estimated time based on your category. So you're never category 1. And currently at the moment, so certainly twice in the past week, I've been told that will be a 2-hour wait. Well, you know, one was a 40-year-old intubated lady with a intracerebral bleed, and the other was a post-VF arrest that needed to get for urgent PCI out of hours, who again was intubated. That clearly isn't an acceptable time frame, and we can't just put the phone down and accept that. So if you feel they need a more rapid transfer, then you need to ask the ambulance dispatch for your call to be scrutinised by a clinical coordinator, as this is a time critical transfer. And you can also, what I find useful is to get their number to speak to them directly. Hence, the documentation of the time that you're requesting a transfer is really important, because there are often still delays, and that's there in your stock tool. And then you can show that you followed the escalation process, because if these are time critical, then the retrospective scope is always going to fall back on how did it take so long to get out of your department. So we have to try and act in the best interest of the patient that we have in front of us. I've mentioned earlier, don't delay transfers for unnecessary interventions. I think the person doing the transfer, if they're not used to doing transfers often, want to make sure it's safe, but there's a balance between safe and what really has to be done to achieve the life-saving intervention for that patient that can't be done at this hospital. So it's working together and pushing and make sure what's necessary has been done, but we get this patient out in a timely manner. And if you have booked the ambulance, you do need to be ready. Okay, so it takes time to get that patient on the transfer trolley. It's when we know that there are patients in the community that can't get ambulances, it's unacceptable for you to book an ambulance and then the paramedic crew be waiting there for 45 minutes while you're still faffing around. So please be ready, please be efficient, and please escalate delays if they're happening. Certainly at my trust, they're also, the anaesthetic department themselves are also looking at ways of a tick box form to try and make sure only the critical things are done for these time critical transfers, so that it helps the doctor going with them, that they don't have to tick every, they don't have to think I really need that arterial line, because they quite possibly don't, or their blood pressure might be being maintained. They don't need that central line now, and they can have some peripheral support with their arterial blood pressure monitoring, and don't need that central access put in. So I think these are really important things to think about. So that's our time critical transfers. Finally, I think it's always important to assess the need for potential interventions en route, reassess this constantly and identify potential complications. So, your respiratory patient, invariably if they're being transferred out, needs that intubation prior to transfer. But it might be other things that you would then be potentially asking your ITU team to do that maybe with outside of their remit. So you have to think of that. So twice, for instance, where I work, I know that EM consultants have gone on the transfer with the ITU team, one where the patient had needed recurrent pericardiocentesis in case they needed it again en route, and another where potentially they were going to need a thoracotomy en route. Now, if that patient is really unstable, you should be thinking of getting the critical teams to your department and not transferring them out. So again, it's balancing that risk of, is it actually safe to transfer, or does the team need to come to the DGH? But it might be that you think it's unlikely, but just in case, there needs to be someone there to do it. So someone has to offer it. Should that be the EM person? They're often core critical skills that we're expected to do. They're very rare. And maybe we're more comfortable, willing to work outside of our comfort zone in a risky environment. Whereas I think certain teams would be, I'm not competent, I'm not doing that. So you have to balance the risks and think of what could change en route. Always, it sounds obvious, but always check exactly where you're going to. So is that the ward? Is it ED? Is it theatres? We've mentioned before, take your phone, wallet and coat, document the OBS every 15 minutes. Always please ring the destination unit before departure. So if you're going to ED, it's also good practice to get the paramedics to give a 15-minute pre-alert, because as much as we have communicated with the neurosurgical registrar where the patient is going and when they will be there, you can bet your bottom dollar that they haven't told that emergency department that they're getting an intubated patient from another hospital in half an hour. So make sure that it's communicated and a pre-alert is given, especially in these current times where it's literally one in, one out, to get a bed in a resus unit, let alone in the hospital, in the ED itself. Don't forget about the parents and relatives. So give them directions to the receiving hospital if they're not going the ambulance. With these unstable patients, invariably they're not going the ambulance. But please ensure that they're aware that they must not follow the ambulance. It sounds obvious, but they shouldn't be speeding along behind a blue light ambulance, chasing their child. They need to be taking it carefully and not causing another incident en route because they're trying to keep up with the ambulance. I think also we can see how unstable these children are and how important it is to work for a team. So I just wanted to reiterate, this more than any is a time to be kind and look out for those who are involved and work together. So that brings me to the end. Just if anyone is interested, the ALSG group run a transfer course, the NAPSTAR course, which covers neonatal, paediatric and adult transfers, safe transfers and retrieval. I'm sure you have a lot of courses you need to go on, but if you have a particular interest, it's got very good reviews. I know there's one in Manchester in November that still has availability, but it's something to think about if you're interested. If not, most hospitals run their own safe transfers in-house. I think it's important to expose yourself to that, to understand the risks of transfer, because the moment you take a transfer lightly is the moment that something will go wrong on that transfer, even if it's just a CT and back. And that is it. So we'll take questions, but quickly we'll try and do this poll just to look at practices within the region.
Just launching the poll.
Thank you. So first question, what level of paediatric care does your hospital provide? So I'm just interested to know whether you're in a level 1 hospital or whether there's some level 2 services, or whether you're all working at Addy's and having a lovely time with PICU on board. I don't know. Oh, well, we seem to be getting more responses. And then, do you have access to neonatal care on site? Because certainly some hospitals don't. And then looking at the ventilators, so do you have access to the Hamilton, Oxford 3000, Baby Pack, and do you feel confident to use it? Do you use your stop transfer tool, or do you use a different one if you don't have stop? So let's give it a second for the results to come in. So let's go back. Question 1. So quite a lot of places work where there is some level 2 as well. So certainly Luton cares for quite a lot of level 2 patients on site with the acuity of patients that we see. And about nearly a quarter of you work where there's level 3. Neonatal care, that's good. So 93% of you have access to neonatal care. Often in some departments, PEDS provide the neonatal service. I think it's useful to have a NICU, but knowing that they often work in their own, their primary responsibility is the NICU, which is often particularly busy, but at least there's some support there if we need it. So quite a lot of you have the Hamilton transport ventilator. And I think if you don't, it's probably coming. They're actually pretty intuitive to use, and because they can be used in all age groups, it's a real bonus. Oxylog have been around, haven't they, for a while, and many people are comfortable with them. And if you don't have the Hamilton, then you do need access to a smaller one, which looks like it is Baby Pack. And more than half of you are confident to use your ventilator. I think it may not be skills that we use day in, day out as an emergency physician or as a pen person, but keeping up your skills, I think, is really important, because actually often the anaesthetists need a bit of support with these smaller children that they just feel that they shouldn't be providing a service to because they're not paediatric anaesthetists, but at a DGH they really have to be able to for that period of time or for the transfer. So it looks like some of you don't need to stop, but you do have access to a different transfer tool. Just make sure it's being done and it's being filled out would be my main point, because I think documentation is where we'll always fall down. And it's amazing how even when you're doing, for me, going through the intubation checklist, I'll always forget one thing. Even though I think I know it off to a pat, you'll always forget one thing. And it's the same with the transfer tool. So I think it's really helpful, and it reduces that element of stress when you're looking after your patient. So lovely, thanks for doing the poll. Let me see if I can. I don't know how to escape. I'm going to stop sharing. There we go. Fine.
Thanks very much, Charlotte. There hasn't actually been any questions in the chat for you. There's a bit of debate around the Hamilton ventilators. Does anybody want to shout out any questions?
So, I mean, hopefully it's stuff that we're used to, we think about, and this wasn't a high level presentation, but I think doing it well is really important for the outcome of that patient. So I think it's worth thinking about and working together.
Absolutely. The best learning point for me was on the time critical transfers, knowing who to speak to, the clinical coordinator. Just that little nugget of information is going to be one that I'm going to keep with me.
Lovely.
Right. No more questions from anybody? Yeah. If not, then I am going to pass over briefly to Ash before we go back to Josie.
Thanks, Catherine. I'm just aware of the time, and it's getting to that time where people might start drifting off to with kids arriving home or to go and pick them up and whatever else. So I just wanted to, before we go off for a coffee break, say a really, really huge thank you to Josie and to Alicia, who've both put in a phenomenal amount of work to put this together. As a lot of you know, PEMEast is, it's a small group of people that are trying to sort of set something up in the region for people that have a paediatric emergency interest. And this is our first sort of foray into a full day of teaching and learning for the region. And yeah, I just wanted to say a huge thank you on behalf of everyone to Josie and Alicia.
Oh, thank you, Ash. Really appreciate that. And we would really appreciate your feedback. So we're learning as we go. So I'll put the links in the chat again for any feedback. And we've got time now to fit in a coffee break that we missed earlier. So if we come back just before 4 o'clock, sorry,